Okay. Good morning. Hopefully everyone can hear me okay. I'm Kristin, I'm one of the fellows, and my lecture is on dexmedetomidine. So we can go ahead and get started. Oh, sorry, this is frozen. There we go. Okay, no disclosures. And the objectives for my lecture is to learn how Precedex can be helpful in end-of-life care, observe dosing strategies, gain comfort in its use, and understand some of the literature limitations. And so just some history of the drug. What?
It looks like there's a poor audio. It's real quick.
Oh,
yeah. Can you guys, is it poor audio for everyone, or because we can try a different way?
Not terrible.
No, I can hear good.
Okay, we just want to make sure because there's a couple ways we could do audio.
Because Gretchen, I can hear your audio better than hers. You guys in the same room?
Yeah, let's switch unless we switch spots. We can do that. I think it is. We're gonna switch locations and that make it to be the easiest.
That's nice. That's a little shuffle.
Just a little shuffle. Yeah, our microphone's in the middle of this table, so we'll try.
That may be it.
How's that?
Sounds good.
history. Okay.
Perfect. Okay.
Yep.
So just a little bit of history about Precedex. So it was discovered not that long ago in the 1980s in Finland, in a lab there. It was modeled after clonidine, but just with more specificity. It was approved by the FDA in 1999, specifically for short-term sedation in mechanically ventilated patients. Was rapidly adopted in critical care settings, especially where delirium and agitation was a concern. Fun fact, for you animal lovers, veterinarians also use Precedex for similar reasons in dogs, cats, and horses. And so I'll be using dexmedetomidine or Precedex interchangeably throughout the lecture. It's a relatively new drug for use in end-of-life settings. It has sedative, anxiolytic, and analgesic properties. It's mainly used IV or sub-Q, but there are intranasal ways to use it and sublingual films, but those films are more expensive. And so just some of the less exciting stuff, how it works, mechanism of action. So it binds to the alpha-2 adrenal receptors, and we have those in our brain, spinal cord, and peripherally. In the brain, it will do sedation and help with anxiolysis, can help with analgesia in the spinal cord, and then have some sympatholytic effects peripherally, which can cause some side effects, which we'll get into a little bit later. More specifically, so in the CNS, going back to medical school, it goes to the locus coeruleus, which is a brainstem nucleus, involved in arousal and vigilance, which I'm sure you all remember. Precedex, it activates that alpha-2A receptor, and it inhibits norepinephrine release, leading to sedation and anxiolysis. In the spinal cord, it works at the dorsal horn, so inhibiting the substance P and glutamate, which are those pain neurotransmitters, and thereby providing some analgesic effects. In the peripheral, it leads to decreased sympathetic outflow, which then results in hypotension and bradycardia, which are some of those side effects that you can see while using this medication. So Precedex is not associated with respiratory depression. It has a pretty short onset of action, so 5 to 10 minutes with IV, 30 to 90 sub-Q, about similar 25 to 45 minutes intranasally. Usually seeing peak sedation within 15 to 30 minutes after IV use. It is 100% bioavailable with the IV and 82% sub-Q, so pretty good. It does have a short half-life, about 2 hours. And it's important to know that it's metabolized by the liver through that glucuronidation and the CYP2A6 pathway. So patients with advanced liver disease, having that hypoalbuminemia, can have increased drug levels of Precedex because it's a highly protein binding medication. Renal dysfunction has minimal impact, but metabolites can still accumulate, so just something to keep in mind. So what is its role in palliative care? We know it's used a lot in the ICUs, but in palliative care, it really should be thought about for those refractory symptoms in end-of-life care. As we know, pain and anxiety can be difficult symptoms to treat. And even though we're using our typical or common, whatever word you want to use, medications, sometimes we have that insufficient symptom relief. And sometimes we run into side effects of those medications and patients can't tolerate them. Being a sedative medication that's not associated with respiratory depression and also having those analgesic properties fosters interest for this drug in the palliative care field. I think, I would think about it as just another adjuvant medication to have in our tool belt. Again, most of the data is surrounding use in ICUs and use by anesthesia. However, there are more and more studies happening in the palliative care world. Right now, most of them are smaller retrospective studies, like prospective cohort studies, case studies. So, one thing to note is we need more randomized controlled studies and maybe larger studies, which is sometimes hard to do in our field. So why do we care about Precedex? What do we use it for? And mainly for symptoms control, pretty long list of symptoms up there. So you can use it in refractory agitated delirium, terminal restlessness and dyspnea, pain, anxiety in patients not tolerating other medications. It can be used in opioid-induced hyperalgesia. It's something you could consider using prior to palliative sedation or as an alternative sedation instead of your typical propofol or Versed. All right, moving on to some of the side effects that we should be aware of. Bradycardia, hypotension, dry mouth, nausea, which are mild and less common, hypertension. So this is, if you remember, kind of one of those special medications where you can get both the hypotension and hypertension. So hypertension comes from alpha 2B adrenal receptors that are, again, in the periphery. Those are usually activated at high doses of Precedex or with like rapid IV administration boluses, and it causes vasoconstriction, which then leads to that hypertension. The hypotension comes from activation of the receptors in the brain and spinal cord, and it inhibits neuronal firing, causing the hypotension and bradycardia. This is also the mechanism that causes the sedation and analgesia. So just something to be mindful of. Low intravascular volume can exaggerate the peripheral effects. So if you are seeing patients maybe get hypotensive after you started or had some bradycardia, trying a fluid bolus can also be helpful. As it can with other medications too. So maybe some instances that we should not give Precedex. Severe hepatic impairment because it is metabolized again through the liver. You know, if you can adjust the dosing or monitor it closely, you might be able to try it, but do that cautiously. Because it's known to cause bradycardia, you would probably not want to use it if a patient has an advanced heart block or significant bradyarrhythmias. And then if a patient's hypotensive and not responding to fluids, you wouldn't really want to start a pressor in an end-of-life setting just to use Precedex. So how do we dose it? So I went to a lecture at AAHPM, and one of the groups presented on their protocol of how they were using Precedex in their inpatient hospice unit. And they just had this table that I borrowed. I thought it was easy to read and nice colors. So basically, it is weight-based and it's an hourly infusion. You typically start in the conservative or moderate dosing range, so in that blue or green section. And you can potentially titrate up every 30 to 60 minutes if needed. So usually, and most of the studies that I read, they're starting around 0.1, 0.2 mics per kg per hour, and then going up as needed. In some of the cases we'll talk about, they really didn't go past 0.6 mics per kg, but just knowing that you can, if you are having a crisis or really bad symptoms, it's safe going up to 1.5 mics per kg per hour. And then just kind of going in between the tiers, so you can go up slowly, so you can go up in, let's say, the conservative tier, or you can jump in between, just depending on your patient. And so kind of thinking about that more, they use this mnemonic called SHIP, which I thought was creative, I guess. Just to, and you could use this for more than just Precedex, but how you would adjust the dose of it. So S is for severity, so how bad are the symptoms? H is the heavy lifting, so is it the only drug you're using, or are you having other drugs going at the same time? Immediacy, what's the prognosis of the patient? And then preferences, so what are the patient and family goals? Just kind of making those adjustments depending on what these are. And so I typically learn best with cases and just kind of reading about it used in different scenarios. So for this lecture, I reviewed a lot of articles, taking you know, overall themes and stuff, and we'll talk about some cases, but these were just some of the articles I used, just, you know, just to share. And so why don't we get into a case study? So this is a 63-year-old female with recurrent breast cancer. She's having intractable pain kind of in her left chest and in her left arm and some swelling with it. Despite treatment, she's had disease progression and declining functional status. She comes to the hospital because of intractable pain, and they note she's reporting pain and just overall distress. She's had, years of generalized anxiety. So on top of her home medication regimen, they decided to start adding on just 0.5 milligrams PO in the emergency department and when she gets admitted. So her home regimen consists of methadone, 5 milligrams every 8 hours, gabapentin 3 times daily, and then oxycodone 10 to 20 milligrams every 4 hours as needed. And she's using that about 5 times a day. So when she comes into the ED, she's in severe pain. Her home med, just isn't working. And so they decided to add hydromorphone 1 milligram every 4 hours as kind of this rescue bolus. So just to give us a baseline, initially her OMEs are like 135 plus 15 of methadone. And so she gets admitted and they transitioned her to a dilaudid PCA because this wasn't working. They did 0.5 milligrams with a 10-minute lockout and then continued her methadone for kind of that long-acting support. With the PCA, her OMEs went up to 230, but she was still reporting severe distress. So the team decided to add back that kind of nursing push, the 1 milligram of Dilaudid every 4 hours. They also decided to add Decadron, Trazodone, and Lexapro, just to help this. I can't emphasize enough how much distress this lady was in. And so the next day her OMEs went up to 390. So in 2 days, she's already over doubled her OMEs and she has not improved at all. So the team said, well, we're not going to increase opiates anymore because she's not really responding to them. And the next like hospital days 4 through 6 just kind of went along. They increased the Trazodone, but then she developed delirium. So she's having delirium with hallucinations. They decided to stop the Decadron, stop the Ativan, and they added Risperidone. They also had IR involved on day 6, who performed a stellate ganglion block and T2 through T5 intercostal neurolysis, just to try to help with some of this pain. So we're at hospital day 6 and really none of her symptoms have changed. We're now at hospital day 7, still no change. I think it's important to note when they were doing imaging prior to the IR procedure, it did show worsening NETs and pleural effusion. They decided to try lidocaine. So they're trying all these things. And on hospital day 10, the patient and family changed to comfort care, although she's still reporting severe distress and saying, I need help, please help me. And so just kind of in the middle of this case, I thought we'd pause for a second and consider just a few things. So we have a patient here with increasing pain and limited opioid responsiveness. And just knowing that escalation of opioids, especially at these high doses, can cause unwanted side effects. And I just wanted to bring this other bullet point, towards the end of life, people have trouble tolerating those oral meds, and sometimes we are limited with our med options and adjuncts like TCAs or gabapentinoids. All right, so hospital day 10, we've changed to comfort care. We're trying all these things. Family's hoping for pain control, but still wishing for some lucid moments so she could say goodbye to her family. They tried chlorpromazine at night, maybe to help with sleep, and that still didn't help, and she became more delirious. Hospital day 11, they had to stop her. They decided to stop her methadone and trazodone. They stopped her lidocaine. She started to develop some dysphagia, and they decided just to transition everything over to a Dilaudid infusion. However, family was hesitant about increasing this infusion because of the sedation that it was causing. And so, surprise, Precedex was started, hospital day 11. And so they started at a very low conservative dose, 0.1 mics per kg per hour. And they noted 4 hours later, she appeared more comfortable. but she was still having some grimacing and calling out with any stimulation. So they just did a very mild increase, and she started to have some improvement. They noted that the agitation and grimacing had resolved. And she was able to have some lucid periods. She was able to talk with her daughters and say some goodbyes. They did note she was still having some intermittent agitation and pain, but it was much more brief and overall improved. And so over the next couple of days, they did make some small increases, just adjusting for breakthrough pain. And at the same time, they did continue her Dilaudid infusion. And so together, between the Dilaudid infusion and the Precedex, hospital day 15, so just over 2 weeks after she was admitted, she was finally pain-free. She had no grimacing or moaning, and she was able to die peacefully on hospital day 16. So just kind of reflecting on this case, this obviously is a very complex case. The team really was creative with what they were trying to treat her with, and just noting that Precedex was given in conjunction with other agents. In this case, it was given outside the ICU without EKG or vital signs monitoring, which we know is often restricted in those end-of-life patients with comfort care code status. Because of the fairly short half-life, they did not use a bolus or loading dose because they felt like they really didn't need it. And in all the other studies I read, no loading doses are being used. And that way you can avoid the hypotension and bradycardia as well. And it works fast enough that just for your practices, I don't think you're really gonna need a loading dose. And then just kind of going forward, making sure you consider dose reduction by about 50% if you're having that low creatinine clearance or if they're super elderly and frail. So that was just kind of highlighting its use for pain. And then let's talk about peds. So it's used frequently in the pediatric world in ICUs and for sedation. In the palliative care and hospice world, it's off-label. Surprise, everything's off-label. But the starting dose is similar to adults. So 0.1 to 0.3 mics per kg per hour, and just titrating slowly. Most of the studies showed relief with doses 0.2 to 0.7 mics per kg per hour through the IV. Again, not needing that loading dose. A lot of use that I saw was intranasally, and besides, we know it helps for pain, but there were some case examples that it was helpful again for anxiolysis, severe dystonia, and sleep disorders. And so I came across a couple interesting uses, so I thought I would share them. So we have a 10-year-old with dystrophic epidermolysis who had severe insomnia. They tried melatonin and benzos and niaprozine, which is some sort of sedative they used overseas. She tried 3 mg per kg intranasal spray of Precedex before bedtime. They did it in the hospital setting first, so they were monitoring heart rate, oxygen, blood pressure, and she tolerated very well, and she was actually discharged home on that regimen. And the family and patient reported that sleep duration and sleep quality improved, along with her daytime sleepiness and pain control. And so, just for our knowledge, intranasal dosing typically ranges like 0.5 to 2 mics per kg every 6 to 8 hours. And then another interesting use, so I came across a 14-year-old with congenital heart disease and end-stage heart failure who was admitted for cyclic vomiting. In the hospital, they were using Precedex to treat the cyclic vomiting. They ended up enrolling in hospice, and the team decided to continue IV Precedex infusion at home to control it. The effective dose for this patient was anywhere from 0.1 to 0.3 mics per kg per hour, and she was successfully treated at home with this for 3 years until her death, so quite a long time. All right, so it has been shown to benefit in those cases with opioid-induced hyperalgesia. It has been shown to reduce central sensitization and NMDA-mediated hyperalgesia, so counteracting those mechanisms. It also can provide an adjunct when you're weaning opioids by providing both that analgesia and sedation. And some of the studies actually show it has this opioid sparing effect. So when you're using it in conjunction with opioids, they were noticing patients did not require as high doses of opioids in general. So maybe even, if we're starting it with our opioids, avoiding that opioid-induced hyperalgesia to begin with. So we talked about, or we highlighted its use in pain, and I thought we should talk about its use for delirium as well. So terminal delirium affects a high percentage of patients in their final days of life. I think it's one of the more difficult symptoms to treat, and pretty distressing for families to witness. I think it's, finding that, trying to maintain comfort and dignity. But sometimes those conventional medications have the potential for oversedation, respiratory compromise, and overall reduction in the ability to interact with the patient. So how does it work? Again, bringing up that alpha-2 adrenergic agonist. So it's decreasing that norepinephrine release and sympathetic tone. It promotes the natural sleep architecture, unlike benzos or antipsychotics that will disrupt it. And it reduces this overall neuroinflammation and catecholamine surge, which happens and contributes to delirium. So kind of going back to that pathophys, not that any of you will remember this after today, but it inhibits the microglial activation, which by activating that, it releases cytokines and you get this inflammatory surge. So it just works by down-regulating those inflammatory pathways. And so there are multiple randomized control trials that show Precedex reduces the incidence, severity, and duration of ICU delirium, especially compared to benzos. It also showed improvement of delirium-free and coma-free days by using Precedex versus like your typical propofol or midazolam. Two of the bigger trials that I saw were the MENS or the SPICE trials. Just noting, these results are not universal, but there are a lot of studies showing that Precedex can reduce the incidence. And so just kind of borrowing that from the ICU setting, I think we would, and studies have shown that we can see that in the palliative care or hospice setting as well. I think it's something to note that Precedex, isn't a perfect or, it's not a perfect drug. It did cause more bradycardia than propofol or Versed did in these comparative studies. So although I want it to be a perfect medication that we can use for everything, it's just not. So how do we use it for delirium in the palliative context? So consider it in terminal delirium when those antipsychotics fail, or maybe we're seeing those extrapyramidal symptoms. It could reduce the need for multiple sedative agents, just kind of easing that caregiver burden. And it's seen most valuable in the hyperactive or mixed type delirium. So for just a case example using this, there was a study out of Canada that was looking at patients with agitated delirium, and it was being treated with the subcutaneous dexmedetomidine infusions, trying to use the RAS-PAL scale, which I'll show to remind you guys on the next slide, just trying to get the wakeful sedation. And they again were using similar dosing, 0.2 to 0.7 mics per kg per hour, trying to get somewhere in between -1 to 1. And so just quickly, I'll show you that. And so 0 would be ideal, just kind of that alert, calm state, but accepting a little bit of drowsiness or maybe a little bit of restlessness is what they were going for. And so the higher you go or the lower you go, it's either more drowsy or more agitated. And so in this study, it was a small study. They only had 10 patients, but 7 out of 10 reached that sedation goal of -1 to 1 on the first day of using Precedex, and they continued for several days afterwards. They noted most of the patients required like 0.4 to 0.5 mics per kg per hour to sustain this state. And one patient out of the study stopped it because they didn't think it worked, and one patient did have hypotension, so it was stopped. But just knowing that we have found it helpful in delirium. So this trial, I'm excited that it's coming out, but it has not come out yet, but just something to be on the lookout for, called the DREAMS trial. It's coming out of Australia, dexmedetomidine versus midazolam for end-of-life sedation and agitation, and it is a randomized controlled trial. Just kind of recognizing we do have a knowledge gap in using Precedex for delirium. And so their study is going to compare Precedex to midazolam in sub-Q infusion at end of life. Both doses will be targeting lighter, kind of this interactive sedation. And it'll be the first randomized controlled trial in the palliative care setting to compare novel versus traditional sedatives. And so they have 26 patients per arm, which from the studies I read is pretty decent. And their hypothesis is that Precedex will provide more interactive sedation at end of life while maintaining comfort compared to Versed. And they're going to be using that RAS-PAL scale that I showed you on the last slide to judge that. And so I know everyone's waiting on the edge of their seat, but results should be coming in the next year. So one of the things I wanted to talk about was withdrawal. So you can get withdrawal using this medication. It's again similar to clonidine, so abrupt discontinuation can cause withdrawal. It's seen, if you're having patients go into withdrawal, you'll see pronounced agitation, delirium, vomiting, tachycardia, and hypertension. The incidence is fairly unclear. Some reported this kind of wide range, 35 to 64% withdrawal, or had withdrawal symptoms in ICU when they were stopped. Some other studies were cited as a lower incidence. And so I have a case example just to kind of solidify this for you guys. So we have a patient with sarcoma, bedbound, severe pain despite multiple opiates, steroids, benzos. And they were placed in the inpatient palliative care unit on comfort care with a Precedex drip. They felt better. In fact, they felt so good that they decided to change back to full code and pursue radiation in hopes to improve enough maybe to go back to disease-directed treatment. And so because they came out of the inpatient unit and went to full code, they had to stop the Precedex just protocol for their hospital. And so they stopped it, and within 4 hours of stopping the infusion, they developed profound increase in pain, nausea, vomiting, tachycardia, and were miserable. And so the team tried clonidine and some Versed to see if they could make some of the withdrawal symptoms better, but it was so intolerable for the patient, they changed back to comfort care. And so they restarted on the Precedex drip, and 2 hours later, the symptoms were controlled again. I thought it was interesting. They commented that this facility actually changed their protocol to allow this patient to receive Precedex and radiation. Ultimately, she couldn't tolerate the radiation and just went back to strictly comfort care, but ended up using Precedex for 38 days in conjunction with some Versed as needed, with symptoms very well controlled. And I think you guys should know, the literature, again, with this being a new-ish drug, the literature is still inconclusive on withdrawal. Some people have it, some people don't. Some people have bridged with clonidine with coming off of Precedex. I think in our setting, most of the time we really won't be like weaning people off of Precedex in an end of life setting, but just something to keep in mind if we do run into it. So some of the limitations and things we need to consider with this drug. So I think we need to consider the cost and the access that, inpatient hospice, home, or inpatient palliative units would have to this medication. Just for kind of reference, so Precedex in a 200 microgram vial is $55. Versed for a 5 milligram vial is $5, and propofol for a 200 milligram vial is about $10. So Precedex is like 3 to 4 times more expensive than Versed or propofol. It is off-label use for what we would be using it for, and so I think that requires just consensus of the team and family education. And it is restricted in the inpatient setting. So personally, the ICUs and the nurses are comfortable using it there, but I've run into issues with staff here being uncomfortable with it, using it on the floor, even for those with comfort care designations. So more education and having people become more familiar with it, I think, is something that will need to be done in the future. Speaking of future directions, we mentioned this before, needing more randomized controlled studies in the palliative populations. I think exploring more of that intranasal or buccal options is interesting. Potentially, developing protocols on our hospice formularies so we can actually use this medication. And then I touched on this previously, just, using it outside of the ICU and having people be comfortable with that. And so, some of the take-home points that I would like people to take away from this lecture, Precedex offers a unique role in palliative care and expands our toolkit. It's useful for refractory agitated delirium, dyspnea, and pain. It is safe at low doses and it has minimal respiratory depression, and growing evidence supports its compassionate use. And so, just so I'm not rambling on for a whole hour, I thought of some discussion questions that I thought maybe we could just open it up and have more of a discussion with our time that's left. And so I'll just read through them, and if anybody wants to comment, I'd appreciate it. So could you see Precedex being used in your practice? Does anyone currently have it on formulary in their hospice? I know as Corewell, we do not. Would you consider using Precedex in a home hospice patient? If so, what would you need in place to feel safe doing that? What symptoms in your practice do you find most distressing and hard to treat in the last days of life? And lastly, do you think Precedex should be part of standard comfort kits or palliative sedation protocols? Why or why not? Go.
Thank you. I was going to say first, thank you, Kristin, for that excellent overview. I love all the case examples too. I think that was really helpful to solidify the different sections of your talk too. So yeah, love to hear.
I certainly appreciate you sharing the PEDS data or examples.
Yeah.
It's something that I have not used at home in hospice, but I know my colleague on the other side of the state uses it a lot. And I'm reminded of that by my hospice team often, or not reminded a lot, but they say, oh, by the way, Kiefer used it. And I've been a little bit hesitant. So this is actually really helpful to get a little more background and whatnot. So I've come close before in considering it in some of those kids where agitation and pain are very much out of control and we're just going up and up on our other trips. So I think this empowers me a little more to think about it. So, and I definitely would use it. We use other trips in similar ways. So I think that it's a great tool potential.
Anyone else out there have comments or thoughts or maybe experiences using it?
I just want,
Yeah, go ahead, David.
I was just saying, I think in the hospice setting, as you brought up, I'd love to use it, but the cost prohibitive nature, it seems like it would make it difficult to use over Versed or combination Versed morphine. I was just interested in the inpatient setting, how much like the hospital systems gave any pushback or balked at using the medication, if anyone had experience on that.
I can speak for, well, my experience, if the patient is still in the ICU and, decides to go comfort care, it's easy to continue Precedex, but I have had, in a patient that is out of the ICU on comfort care, we thought of using Precedex, but felt we would get so much pushback from the nurses that we didn't use it. And we're working on actually trying to come up with a protocol here at Corewell so we can use it more and have more education for the nurses. So it's something we're working towards, but definitely still in process.
Yeah, and I can share a little on the history of that. Let's just say when I joined here 2017, really between 2017 and 19, we did a lot of work to even just for set on the floor. That was dazzling, I should say, in these lecture times. That some had to be worked through because that wasn't being used as often at that point, and now it is. But what we ended up doing is working with our pharmacy department. I mean, there's a blanket statement in nursing and protocols for pharmacy that if someone is comfort care, then really we can use any of these medications. And it may even expand to palliative care as well. If the palliative care service is ordering So I'll have to double check on that for Precedex, but definitely a setting of comfort care. So that we are allowed to. And we built this trust with the pharmacy team. The thing is though, not all nurses still feel comfortable. And so we thought, well, in addition to the pharmacy policy saying that we want to have a protocol, like this is how we dose it, this is what we need to look out for. And then maybe this will be opportunities to meet on nursing units and having education so that people do feel more comfortable in those rare cases so it's been a journey and a process through it, but hopefully with Kristin working on this, we have a medical student Trinity here on the Zoom meetings. They're working on this project for making a protocol.
So just a quick question. I mean, I don't use it. I really want to, and I really, I mean, I just don't. But for terminal delirium, considering if there's like no other obvious contraindications, should we still be thinking of Versed before Precedex?
Yeah, I think that's a good question. If we didn't have to think about like cost or anything like that, I think it's something to consider, but in all the studies I read, it was used as like, we have tried Versed, we've tried these things and it's not working, so now we're going to Precedex.
Okay.
So I think it would be interesting, you know, would anyone try this first? I don't know if anyone has.
Well, and I'm sure you guys run into this as well over at Corewell or any of the inpatient settings where patients with dementia come in and have that agitated delirium, and the facility can't take them because of their behavior, so they come to the hospital. And the question always posed is, palliative care help us control or manage these behaviors? They might not be hospice appropriate yet, but that agitated delirium is there. I'm curious if anybody else, we have not used it ourselves much at Trinity for that sort of situation. I can see it being beneficial. But I wonder if anybody else has had experience, like personal experience, using it in a setting like that.
No, but I think it's a good thought, like if you've got a patient like that coming into the hospital because of behaviors, but not quite hospice appropriate, like you were saying, like could that mechanism of action with this particular medication and it promoting a natural sleep architecture, whereas like our antipsychotics don't. So they're sedated, but they're not getting good rest. They're not getting that good like REM. They're not falling into the REM sleep cycle. So there's still like they have that groggy sensation and side effect. And how does that lead into more delirium? You know, so could this in like you said, like an inpatient setting help break that cycle and get into, okay, now we can wean off of that and go back to other medications that could be continued in their not assisted, but like their skilled nursing or memory care type location or at home. So I wonder about that. And Kristin, you made a joke about, oh, everybody on the edge of their seat for this upcoming trial, but I think it is kind of exciting. I wrote it down to look up later, you know, that comparison of Precedex versus Versed, you know, that's like you had mentioned, a knowledge gap. And, you know, like Simon said, is this something that we should look to going to before Versed, or is this something that we try after we've exhausted everything else? I think a trial like this is, you know, one of those key pieces of information that help move the field forward. So thank you for bringing it to our attention. This is a really great lecture.
Yeah, thanks.
I was curious about the route of administration. I mean, I think all of this being said, just to your guys' point, I mean, like, then what do you do when they go back? You know, and if it can be given another way, like intranasal, I mean, I don't know, I'm pulling out the inner John in us. Can it be made into cream? I mean, if you could.
Yeah, the IV, sub-Q, or intranasal.
And then buccal as well.
Because I think that would be a big downside for its use is if it's only IV, it's gonna be hard to give in a non-hospital setting.
Well, Kristin,
Yeah,
Kristin
but
can come back and give this lecture again with updated information. She can be our Precedex expert, and you can be our buprenorphine expert, and
Well, I'm curious of the modes of administration. If you're using this for delirium or agitation, how are you gonna get a film inside the mouth? Or
yeah.
how are you gonna get medications up the nose?
so we need the cream.
That's right. The onset of action for intranasal compared to like for SED is like, whoa, that's a long time. So I wouldn't, unless you couldn't use IVs like in home setting, makes sense. But I was just surprised, like inpatient, I'm like, why, if you have an IV, it's like 25 to 45 or some way longer than I thought. Yeah. There's a question in the chat. Are you mainly considering using this in comfort care? So versus like if someone's not being helped?
Yeah, so in these studies, these patients were comfort care status. However, it's so safe. It's safe that, I mean, I personally would use it if they're not on comfort care settings. I think it's worth trying. I don't know how the hospital administration feels about that, but
I'd like to add it to our protocol that if our team's involved, one of those restricted.
yeah.
From a cost perspective, I wonder if, like at some point in time, if we're able to show the value of using that in the situation that you had described, like could we get these distressing refractory agitation, delirium symptoms under control faster and reduce length of stay? And so from a cost perspective, like, oh, let's $55 for a vial of Precedex versus the cost of another day of inpatient stay. Just thinking of like, how could you promote this as like something to add to your toolkit?
Yeah.
You know, follow the money, right?
Right. I want to ask, there's comments from F000788. Is that Fitz? I'm just guessing by the context.
Yes, it's me.
Oh, perfect. All right. So I like your comments there about cost and efficacy on the hospice side of things. So Fitz says, you inspired me, more to come from Trillium. So let's experiment.
Wow. That's high praise right there.
And you did say you wanted to get more research, going, so.
And the West Michigan trial.
Yeah,
there you go.
Exactly. Well, if we get it
Multi-center, yeah.
funded, I mean, then we don't have to worry about costs.
That's true.
No, I think we have Trillium is a great place to trial things. And we've all been very busy and really haven't had the opportunity to collaborate. But I think we could all collaborate. And so if you have things like this and you need a place to do it, let's maybe have some meetings or some discussions offline. And because we have been remiss, we can do anything there. So let's talk more.
Yeah, sounds great.
Exciting.
I would say a couple of years ago, we had a couple of cases where this Precedex in comfort care is very effective, and it was patients who had the refractory agitation, but there's also that, that total pain. There was maybe pain, but there's also distress, that's psychosocial spiritual distress. So those are the patients who responded so well. And since some of your case examples, those are maybe some cases too when opioids are not going to be enough. And usually the benzos help, but then sometimes you don't for whatever reason. But I think that was the pattern we were seeing. And again, that's just our N of like 2-3 patients from that 1 year.
I'm going back to the basics. Is this similar to clonidine?
Yeah.
So couldn't it be in a patch if clonidine's in a patch? Or is it just it's not that simple? Or someone would have done it already.
Yeah,
I have no idea, but if you want to look into that,
Let's make a drug.
Yeah.
Let's start.
Next year's.
Yeah.
Great idea.
Exactly. See if we can get somebody to compound it into a transdermal patch.
Yeah.
I'd be curious about the pharmacokinetics of that. Maybe bring in a pharmacist to the conversation next time.
Yeah.
Be about that's with the Dexmedetomindine transdermal patch fast tracked for something, but it doesn't work. So it's out there.
In the works.
It's in the works somewhere.
Oh. Maybe someone's working on
But then again, the link doesn't point where, so maybe it's no longer.
it. Okay, they stopped.
Someone thought about it.
Yeah, interesting. We have some pharmacy residents at our institution, so that may be a good project. They've been involved with some of our changing of protocols and things, or yeah, policies.
All right. Well, thanks for listening, everybody.